welcome. Thank you for attending today's webinar with Advanced Orthomolecular Research and Dr. NivNirat Nibber. I am Kaylee. You can't see me on screen right now, but I am here in the background and I'm part of the Fullscript team. We're very excited to have Dr. Nibber here with us today to help us understand ageism in health, including age-appropriate screening and therapeutic programs for clinicians. So before we get into the presentation, I just want to give a reminder that this webinar is being recorded. So everyone who registered, or if you have to leave early, or if you want to watch it again, you'll have access directly to it from your inbox, as well as all Fullscript's webinars live on our website at fullscript.com/webinars. So you can see everything there as well. And we will have some time at the end of this presentation for a live Q&A with Dr. Nibber, and you will see on your control panel or your GoToWebinar dashboard a question section. You can add your questions in there, and we'll get to them towards the end of the presentation. So again, I'd like to thank Dr. Nibber for being here today. Dr. Nibber is a graduate of the Canadian College of Naturopathic Medicine, a registered naturopathic doctor, and recipient of the 2015 Naturopathic Honor Award. She runs the Women's Health Collective in Surrey, British Columbia, Canada, in addition to her clinical and consulting work. Dr. Nibber is a medical advisor and brand educator for Advanced Orthomolecular Research, engaging with international research in the naturopathic field, and is published health expert in over 25 international publications. I could probably go on and on. I know it's probably a little loud in my background, so I'll pass it over to Dr. Nibber to take away, and I'll rejoin a little closer closer to the end for a live Q&A.
Thank you so much for that introduction, and welcome everyone. It's such a pleasure to speak to colleagues and just get an opportunity to speak to something I'm so passionate about, which of course is ageism in healthcare and how we can start confronting our biases, recognizing opportunities to serve the patient populations that we see much better, much more appropriately, honing in our treatments. I think as healthcare practitioners, that is always the goal, to be able to provide better quality care. I thank AOR for allowing me to present on their behalf, as I work quite closely with them, and for, of course, Fullscript for giving me this platform. I do want to have the technical disclaimers of this has not been reviewed by FDA or Health Canada, and it's really meant to be kind of an educational ongoing discussion. And that lovely introduction kind of positions me as this brand educator for AOR, but really why am I speaking to this? Why should I? Other than the fact that I am aging, as we all are, I guess that's my area of expertise, but from a young age, I was able to recognize that there was a lot of anti-aging rhetoric. There was a lot of ageist policies and practices in small community hospitals and nursing homes that I would work at. And it seems to have been exacerbated by some of the challenges that we faced over the last 3 years. So it seems that now more than ever, we have access to understanding people's needs, and especially access to reducing the loneliness that may be facing certain communities, or that isolation. But first, to do anything about it, we need to identify the problem and maybe have a little hard discussion. So I guess that's what we're here to do today. This is hopefully going to provide you some tangible tools on how to implement best practices and clinical considerations on how we treat geriatric populations, and what we can do in terms of the language, internal biases, and perhaps eventually change some of those policies. We in Canada, and I understand many of you are actually in the States, so well, sorry, that's the map that I found, but some of these statistics in Canada are showing, and there's a similar trend, that we do have this aging population. From 2016 to 2021, we had an 18%, 18.3% increase of those who are 65 and older. And there's, it's doubled since 2001, the number of individuals who are 85 and older. So as an aging population, we really need to recognize that there are some unique needs, and 1 in 17, which is, I would say, too high of a number in Canada, of individuals over the age of 50 are actually experiencing frequent healthcare discrimination, and that is associated with a new or worsening disability by 4 years. So essentially, we're expediting and accelerating some of the impacts of aging by possibly negligent care or overseeing, or there can be the benevolent or the almost unaware biases that are starting to infiltrate, and it is actually translating to people having worse healthcare experiences. The impact of COVID, of course, has exacerbated this, as you know, a lot of the discourse around the pandemic really strengthened this singular view that older adults are vulnerable, they're socially stigmatized beings, and there may be a hostile or benevolent kind of expression of that ageism. And a group just published a paper in 2021, February 2021, that outlined a lot of these concerns that are specifically related to the rhetoric and isolationism that happened during the pandemic, especially within nursing home populations. So what is aging and how is it actually showing up? We know that this is not a new term. It's old. In 1969, Dr. Robert Butler introduced this concept that there was a systemic stereotyping and discrimination that is implicit or explicit. And as we delve deeper into the intersection of other areas where maybe we're seeing other groups being marginalized, this is just another layer that we need to bring much more awareness to. And in Ontario, the Human Rights Code specifically highlights the fact that we have a right as humans to be free of discrimination within our healthcare, particularly in and around our age. We know this is manifested or started to in workplaces, but we do know that if we don't check ourselves, we will wreck ourselves. And that is a scientific phrase. But essentially, we're saying that the micro, so these are individual thoughts and emotions and actions, can be informed by those meso levels. So these are groups or organizations and social entities that then also can impact macro, and these are all interacting and coalescing into ultimately discriminatory acts or feelings of isolation. So on the macro level, these may be political regulations, whereas on the meso, these are, you know, social entities. Do we have sufficient support groups and work environments, healthcare services? So sometimes as healthcare practitioners, we're operating in that meso realm. There's also strongly ableistic undertones of that kind of drive a lot of ageism. As we know, with ageism, there are certain considerations and certain faculties that may start to degrade or be altered, and to expect that someone is able to operate with, you know, full capacity, or for example, if there's hearing difficulties or visual difficulties, to not allow for proper advancements within your space to accommodate that can sometimes in itself be a form of restriction, isolation, because you're now making your space less accessible or your care less accessible by reducing that. And that, of course, is ableistic in that it's suggesting we all should have the same sensory capabilities. So these are certainly things that we need to start looking at, particularly in healthcare. How is this showing up? We know that, like I mentioned, the inaccessibilities within the facility itself. Yes, we have access now to virtual care, virtual platforms, but is that now restricting certain groups that maybe don't have the digital acumen that we expect our other patient populations to have? And even the lack of foresight to design accessible spaces. I mean, particularly if you're building out a new clinic, I hope that this perhaps can elucidate some of those considerations. Can I make this more wheelchair accessible? Can I ensure that, you know, I'm looking for ground level places? Do I have ease of access for my digital communications? And an opportunity to help walk someone through that process. So that's just getting into the building. There is this concept of elder speak, and in 2021, a group of researchers actually looked at the detrimental effects of elder speak. So elder speak is this attempt to communicate more effectively with older adults, but it often ends up being in a oversimplified language, highly rhythmic. You change the tone and pace, and then you just start talking to someone like this, and it can be really patronizing, and it reinforces that unequal power dynamic, and you can lower your ability to gain informed consent because you are now changing how you've spoken to them. And it can create barriers. It can increase resistance to care, and is often seen in groups who may have some cognitive decline and the caregivers as well. So elder speak has kind of been related to infantilizing patients. There's also the concern that ageism is showing up in healthcare by the inability to help really distinguish, you know, what are normal signs of aging and what is pathological. And that, as we'll see in the next slide, can lead to over or under treating or poor diagnostic solutions. There was another study in 2021 that looked at visit times, and in geriatric populations, there were much shorter visits. And those shorter visits led to either coercion or less emphasis on informed consent, and often increased prescriptions, whether they were necessary, medically necessary or not, and ultimately increased costs to patients and the healthcare system. So these are considerations that we actually need to start seeing. This is impacting the doctor-patient relationship. Are we hyper treating and trying to offer solutions where there isn't any necessity? Over treatment with polypharmacy, increasing surgical complications by requesting unnecessary or elective surgeries that are not supportive of the patient's overall health goals, and high patient time and financial investment, so increased trips to get to the doctor, which may require increased time in terms of travel or booking accessible transportation. And then that paired with there may be undertreatment that's happening in terms of delayed diagnosis and treatment because there isn't that delineation between normal aging and what may be pathological. So things may get written off as, well, you've aches and pains because you are old. And then there's exclusion from clinical trials, which is also making it difficult to make some evidence-based informed decisions because certain groups aren't being studied in those rigorous terms, and we're thus under treating. And ultimately, this can lead to serious illness. We do have statistics on how this ageism manifesting in healthcare is decreasing life expectancy. And the number you might be seeing floating around is 7.5 years. So decreasing life expectancy by 7.5 years. So this was actually based off of a study in 2002, which was a observational study that found that older people who hold negative attitudes towards aging had a lower life expectancy, but in 2020, 2020, there was a reinforcing of that concept, and they actually looked at healthy life expectancy based on populations and their different relationship with aging, and found that while that number is harder to pin down, there does seem to be some proof that the attitudes that those individuals themselves hold can be strongly and directly influenced by the relationship with healthcare providers, and yes, ultimately that we can change people's lifespans and their well-being and approach to their own aging. We do know that rates of untreated mental health concerns, particularly loneliness, leading to depression and social isolation, which we'll talk about. And then, of course, avoidance. This can be social avoidance. It can be avoidance of treatments or not seeking out care when medically necessary. Overall higher healthcare costs. We know that some of that is needed with an aging population, but when we are not confronting our ageist beliefs or policies, that does seem to go up. And this can cause elderly abuse and more poverty among older populations. So how do we start managing that holistic health? How do we actually recognize that, okay, aging bodies do have unique requirements, but when we are treating and managing this, we're not pulling in ageists or ageism to influence this baseline. So I think when we look at it, we almost have to look at it from that strictly physiologic, practical sense of there is certainly cellular aging, and then there's the physiologic aging. When we speak to cellular aging, we are looking specifically at the rate limiting step of once you keep replicating with telomere shortening, you ultimately will reach the Hayflick limit, and that is the inherent stop point of cellular replication. And what are the lifestyle and environmental factors that are going to promote that cellular senescence? And is there things like oxidative stress and over loss of compensatory mechanisms and accumulation of inflammatory biomarkers that are actually going to ultimately damage our DNA, damage our expression of DNA, and these can be things such as UV radiation. It can be the normal metabolism, toxin accumulation or exposure, these copy errors. When I mentioned the oxidants earlier, that can be accumulation of oxidants can ultimately be toxic to these cellular replication cycles on a number of places. So it does seem like a lot of healthy aging treatments and approaches deal with antioxidant support, and I think there is a discussion to be had there about overuse of antioxidants or appropriate use of antioxidants, and making sure that you're providing them in a chain or a synergy network, so that when you're doing those electron transfers, there is always a recipient to receive, and there's sufficient antioxidant chains essentially available. And ultimately, how this can then, on a cellular level, help with our mitochondrial function. I think a growing and exciting field of medicine is mitochondrial health, and it seems to be that this has always been positioned as an anti-aging mechanism, but mitochondrial health and can inform metabolic flexibility. It can influence our risk of chronic disease or disease progression. And we do know that there are factors which can improve or decrease. I always liken the mitochondrial function to being that kitchen of our cells. We want it to be well ventilated because we're producing a lot of energy, and we certainly don't want a lack of ventilation to increase those toxic fumes. So there has been a lot of movement towards understanding the role of NAD and NAD+, which can actually function as coenzymes and substrates both in the energy production cycle as well as for cellular signaling. So this concept of the NAD plus to NADH ratio is being examined on how to reduce oxidative markers and ultimately increase that cellular energy. And by virtue of that, the more cellular energy, the better and more robust overall mitochondrial function and mitochondrial biogenesis that can happen. So just going back to this one, so this mitochondrial biogenesis, which ultimately protects against these mitochondrial and age-related disorders. Yay. The goal, I think, for a lot of these studies was how can we increase longevity? And these, of course, are being done more so in animal and preclinical type settings. How can we then relate that back to age-related metabolic dysfunction in humans? And this still remains, I guess, largely theoretical, though we're moving more and more toward understanding that physiology. So we know, of course, NAD+ is inhibited by this aging process. And so the goal for many therapies now is increase this NAD+ through a number of mechanisms. Exercise, caloric restriction, fasting maybe has been coming up, sirtuin pathway mediators such as resveratrol, and intermediates of the Krebs cycle. So supplementation with parts of these intermediates are thought to inform or shift this NAD+ to NADH ratio. So this is all kind of helping with that, if we come back here, with this cellular aging piece. So particularly helpful in those who are experiencing or exposed to highly toxic or highly metabolically active states. So once we kind of get a handle on that, there is, of course, the physiologic aging. And these are changes in physiology that, while are formed by those cellular aging processes, are often actually the thing that brings a patient in. This is the stuff that people actually come in complaining about. So I've broken it down into 5 sections for our discussion today. So these, of course, are the metabolic and renal, as this can inform our energy production cycle disruption, toxic burden, the liver function and renal insufficiency, and can influence the endocrine function. The cardiovascular and respiratory, we know that there is a number of very significant changes that happen to an aging cardiovascular system that do need to be addressed, and often prescription for these medications in the elderly is one of the highest that we actually end up prescribing. So certainly I think people are looking for a lot of support there. Support for digestive changes such as absorptive capacity, reductions in absorptive capacity, changes in appetite. The structural changes, losses in muscle mass, diminished bone density, these can really impact quality of life parameters, pain indexes. Skin changes can inform some of those changes that we naturally see in skin, and seem to be targeted right now by this anti-aging, look your best, live your best wellness movement, which, yeah, we do have to be careful because there is a huge benefit that we can derive, but is it contributing to an already ageist rhetoric or dialogue? And of course, how does this then relate to the cognitive and mental health aspect, either with neurodegeneration, functional processing? How do we ensure that individuals can kind of help? So how can we support them in supporting their cognitive health? So we'll kind of go into each of these sections, and then we'll go through how to actually integrate this into your practice. But awareness of hepatic and renal clearance is particularly important for pharmacists, as I will tell you. These changes in liver metabolism, in renal clearance, do impact our ability to prescribe and effectively prescribe, and I think is often the bane of many pharmacists' existence, in that there, needs to be more data in how, liver volume changes and renal blood flow changes are changing clearance of many of these drugs. So we know both liver volume and blood flow decreases significantly with age. And there is a decrease in cytochrome P450 activity, as well as drug metabolism. And this can certainly leave individuals susceptible to drug-induced liver injury. So I think many functional healthcare practitioners are looking at how to support the phase 1 and phase 2 metabolic processes. We do seem to see a trend in, with phase 1, there seems to be a bit of a slowdown in that metabolic function, whereas phase 2 is usually stays pretty competent as we age. But that can certainly change depending on again that liver volume and blood flow. And then we do know that anatomic abnormalities then related to the kidneys can change also the kidney size. We can get more risk of glomerular sclerosis. Tubular structure can be altered, and the vascular flow is changed. So what that ultimately means is we can have increased excretion of drugs, and it does seem to be correlated with about 26% of all adults over the age of 70 have some degree of chronic renal impairment. And we know this because, of course, we do make those calculations in an age-related manner for filtration rates. EGFR ranges change, and we know as one ages, these are going to change. So that can really substantially impact dosing of medications and clearance of renal through renal metabolism. And we know that cardiovascular impacts can also change, of course, renal metabolism, and we know that that also then in turn impacts blood pressure and blood pressure regulation. Cardiovascular and respiratory changes in an aging body are seen primarily again from that structural and functional changes in atria and ventricles, valves, myocardium and pericardium. We do see that hardening, stiffening, and the cardiac conduction systems, even themselves, begin to change. Of course, we know that age is a risk factor for primary and secondary cardiovascular events as we age, and being a male, being a smoker, BMI considerations, these all do play into your overall cardiovascular risk. But one of those is inevitable, which is, of course, the aging. So how do we increase arterial plasticity? Again, this is related to ensuring a preventative approach of ensuring regular cardiovascular exercise, increasing our flavonoids that are in a Mediterranean type diet, increasing those dietary fats, those healthy dietary fats. And we can certainly look at cardiomyocyte support and actually supporting the myocardium, pericardium, but then also nitric oxide production. And this is an interesting kind of realm. As we know, nitric oxide is a vasodilator, improving blood flow, and can help with delivery of a lot of drugs, or again, we're non-specifically increasing blood flow, but it seemed that in the past there was the L-arginine pathway, and then there was the nitrate reduction, nitrate to nitrates to nitric oxide pathway, which is a little bit more indirect. So L-arginine, using the nitric oxide synthase into nitric oxide, seems to be more dependent on your environmental cues, and so isn't as effective in hypoxic situations, whereas nitrate reduction, oxidation reduction into nitric oxide allows for nitric oxide production even in hypoxic situations. So this is why, you know, having beetroots with high potassium nitrate in it seems to confer some sort of increased longevity in long endurance exercise like bike riding. There seem to be some benefit because now you're increasing your nitric oxide production. So this does seem to be provide some protection, improving function of blood vessels, and there's, as you can see here, lots of potential benefits here from supplementation with nitric oxide precursors there regularly throughout the life. So moving into how this can impact our you know, other changes in physiologic aging, a big one I think we see as holistic health practitioners is digestive function. We do see a decline in gut function. It can show up as changes in taste, esophageal sphincter motility, so things getting stuck in patients' throats more, delayed gastric emptying, the myenteric plexus, it becomes less attuned and reduced signaling with neurons, so that gut-brain axis is somewhat compromised. And that is, again, impacting your gut transit, which can impact your nutritional status and the makeup of the microbiome, increased risk for MMC dysfunction and SIBO. And we know that aging also has those structural and functional defects. So those mucosal defenses are diminished, diminished surface area for of intestinal cells, decreased short chain fatty acid production. So there's, you know, quite a lot in terms of each aspect of digestion that gets impaired as we age. And approaches do need to be taken in a stepwise fashion. So identifying first if stomach acid and enzyme production is sufficient. We're seeing more and more that food tolerances and nutrient deficiencies exacerbate and also result from these conditions. And with polypharmacy, that can impact stomach acid production as well as those enzymes. We know that poor gut motility can impact our microbiome and where everything is. So correcting and addressing any dysbioses. And then with the decline in absorptive surfaces, recognizing the role that inflammation plays in this and correcting and quenching some of that. And then changes in appetite related to sleep and stress, and we always want to be taking a very holistic approach. I think we all already do that, but optimizing digestion does mean removing those dietary irritants. It may be adjusting the types of or delivery mechanisms of supplements that they are taking, ensuring that supplements are being taken in the best absorbable form, so those which are fat soluble and those which are water soluble. If injectables are a preferred option or mechanism, that might serve them better if they still have proper kidney clearance function, then IV nutrient therapy can be more effective more quickly depending on the degree of nutrient deficiency. Of course, we want to heal any intestinal inflammation utilizing natural anti-inflammatories when possible. Things like curcumin, boswellia seem to come up a lot in practice. And then restoring a balanced microbiome, like I said, correct any dysbioses with antimicrobials, and then replenish, so a weed and seed protocol. So weed everything out and then reseed it to ensure regular bowel movements. And we know prune juice used to be laughed at for that's just what my grandpa drinks, but there's some good benefits there and some good use there that can help regulate our bowel movements, and then correcting those nutrient deficiencies and providing proper and appropriate supplements with the proper route of administration. Okay, this is structural changes is a big one that, again, these can influence the, I guess, quality of life parameters, and often comes back to what people actually come to your office with. So we can see distinct changes in muscle mass as we age. Bone density, of course, is a huge risk factor for immobility, joint support, and skin changes. So we know with sarcopenia, this age-related muscle loss is a natural part of aging. Of course, after 30, we can lose as much as 3 to 5% per decade, but that increases more exponentially after we hit the age of 65. And this then also influences distribution of fat and muscle throughout the body, and ipso facto also our hydration status. So there is a higher risk of being more dehydrated more regularly as we age. So a study that was published in Nutrients suggested that, of course, as we age, we increase our protein requirement to about 1.3 grams of protein per kilogram body weight in older adults who are doing resistance training. And of course, adding in that resistance training, because that has the added benefit of supporting bones. And with bone health, I'm sure anyone who supports and treats patients who have osteopenia, osteoporosis, the treatment and management options once the train has left the station become significantly harder, whereas a preventative approach that doesn't stigmatize, again, an anti-ageist approach that is still supporting your long-term health, particularly with bone health, really needs to start, in your 20s or earlier. We need to ensure that we're doing resisted exercise, that where it's not just about calcium intake. Many of our patients sometimes just jump to inferior kind of calcium supplements that they'll get off the rack, but they do need these other cofactors, vitamin K2, D3, to support and help with balanced bone regulation. And then certainly we want to avoid fractures, but maintain mobility. Mobility can also really be influenced negatively by things like joint pain, and as we know, inevitably those aches and pains that can arise when injuries maybe are building on one another or were never fully managed. And again, a core of a lot of this is inflammation that is either unresolved, and so maintaining healthy weights so that there's less pressure on the joints, and then reducing that inflammation can support and help mitigate and reduce a lot of that joint pain, which helps with the mobility, which then helps, hey, who would have thought exercise is good? That's what this is saying. And then also, sorry, speaking to the polypharmacy predicament that I think a lot of patients are finding themselves in, which actually can, they're taking for, joint pain, they're taking a bunch of NSAIDs, but then with the digestive changes that are happening, that reduced absorption or absorptive capacity then can also have that feedback cycle. So being aware of and making sure that we're managing their polypharmacy in a meaningful way and reassessing when they don't need to take anything anymore. Okay, skin changes. We know that we have our endogenous sources of skin breakdown and our exogenous sources. So exogenous seems to be the one that, these are environmental factors, radiation, air pollution, cigarette smoking and UV light. So let's wear sunscreen, encourage individuals to wear sunscreen, and particularly important is melanated individuals. So again, I'm in the South Asian population, it seems quite difficult to get my grandpa to wear sunscreen, and there just wasn't that earlier education in ensuring that darker skin does need sunscreen, and we do need to ensure that we're protecting against burns and reapplying that sunscreen. And then the endogenous sources, as we spoke to earlier, with the inflammation and metabolic changes, again, increasing that metabolic toxic load through environmental exposures. Part of one of the studies looked at individuals living in very old homes that haven't had any upgrades, maybe more susceptible to molds and internal environmental changes that can actually, again, cause, that's the exogenous meeting the endogenous, and this can cause free radical damage and ultimately cellular damage. So you start to see that on individual skin. Again, this is kind of that extension of some of those extrinsic aging supports. And then we do know collagen degradation can cause that skin to lose its structural integrity. And I know that is also a big marketing push in the beauty industry, is collagen, exogenous collagens as marine types. We know that the multiple types of collagen, there can be support for joints, there can be support for skin, and there does seem to be some variability in whether it's denatured collagen that you're taking. There's less benefit, but it still needs to be hydrolyzed, so it's small enough for absorption. So quality of collagen supplements does seem to be quite important, and that again can be its own hour-long discussion. This is an area I'm very fascinated by, and I think is so important. We're seeing so many changes in the knowledge available for understanding how cognition and memory changes with age-related changes. So traditionally it was thought, you start aging and cerebral atrophy, takes over, and we get neuron loss, shrinkage, and an overall change in brain size, which there does seem to be a modest reduction, so 2 grams per year from 26 to 80, and then after 80 there seems to be 5 grams of loss in size per year. But that cerebral atrophy seems to be a non-specific finding, and it does occur normally in the aging brain, but particular cerebral atrophy can happen when it is related to brain injury or degeneration. And then we do know that certain pathologies have very distinctive patterns of atrophy, and there can be different involvement in different brain areas. So we know hippocampal or amygdala or global brain atrophy are early markers of Alzheimer's disease. So identifying that pattern and what cognitive faculties are actually being impacted is going to be important in terms of helping support that overall cognitive capacity. As we know, if it's in the hippocampal, that hippocampal atrophy is impacting your memory and your learning. And we can expedite this neurodegeneration through tissue damage, so untreated traumatic brain injury, excessive reactive oxygenated species, chemical exposure, heavy metal exposure, you know, in unclean drinking water or in those lead paints that are in some old buildings. There was this notion, okay, age means cognitive decline, but this is a helpful diagram that shows that not every cognitive faculty, so, you know, inductive reasoning, spatial orientation, declines at the same rate, and some of them actually can peak later in life. So a good example of this is, if we go here, spatial orientation can actually stay quite high, and then it's lower to begin its descent or decline. And so age doesn't mean that you always have cognitive decline. It just means that some of these cognitive faculties are changing. So you may be losing perceptual speed, but numeric ability, well, that one's also going down. In my case, it's just start slow. So the goal is always to identify, again, this is one of those concerned with not writing off everything as pathological, but recognizing what normal aging in a brain can be. So these can be retrieval deficits, some memory impairment, some difficulty or with word retrieval. However, again, when we know that it's an impairment that is exceeding what is normal, quote unquote, these are, you know, they're benefit very little from having a clue or any cues to solving that memory impairment. And this, of course, we know can be impacted by our sleep stages. With senior populations, there is a regression into a biphasic sleep pattern, whereas adults, we exhibit more of a monophasic sleep pattern, where we sleep and then we're awake. So this biphasic pattern in old age does mean repeated awakenings throughout the night, and then those very early morning awakenings. So this shift in circadian rhythm and circadian rhythm needs can also mean that that same sleep approach, like taking melatonin and just trying to, or any sedatives or any hypnotics, those may not be as effective or may not be addressing that change in circadian rhythm. So they might end up doing more harm. And a 2014 study suggested that delayed or time release formulations of melatonin are more ideal for young adults who have sleep disturbance, as it's kind of mimicking that natural output. But then a delayed release melatonin for an elderly person who is already moving into this biphasic rhythm can actually overly prolong this melatonin increase beyond the night, and then it causes significant adverse side effects. And so the recommendation was, in older adults, have the lowest possible dose of an immediate release melatonin. to best mimic that natural phase change. And overall, we do know that these sleep changes occur, but again, in honoring and recognizing that and supporting that instead of trying to override and keep it, manage it as though it should be the adult is the norm, that monophasic is the norm. From a treatment option perspective, I think we know that there's lots of support for cognitive health from a preventative standpoint. A lot of new research is focusing around supporting BDNF, brain-derived neurotrophic factor, and this neurohormone is thought to support neuroplasticity and neurogenesis, and seems to be increased with, the caloric restriction, regular exercise. There are some mushroom extracts that are being investigated for that, particularly lion's mane. And then, of course, that ensuring that there's sufficient deep sleep. So that's going to be that restorative phase 3 sleep. And in a biphasic pattern, that's happening, we're getting less sleep-wake cycles. So ensuring that in each phase, you're getting about 2 or 3. So good quality, uninterrupted sleep in each of those phases. It's okay if they wake up in the middle of the night. A big one, and I don't want to underscore its importance, but our mental health and well-being, in particular, sorry, like I mentioned at the beginning, COVID has changed a lot of mental health considerations, a lot of our access to understanding the impact of depression, anxiety disorders, the isolation and loneliness was studied in a number of individuals who were in nursing homes over the past 2 years, and it does seem, of course, that there is this association with depression, accelerated cognitive decline, and mortality. And this was attributed to the fact that there was again quite a lot of ageist rhetoric coming out about further isolating individuals, and this was happening on micro and meso levels, and arguing that there was a number of stereotypes. So around the isolation of elderly individuals. So it seemed like chronic social rejection can incline older adults to actually avoid and withdraw from social participation. And this was happening, well before the pandemic, and then restricted even further. And then individuals can also self-embody a lot of stereotypes of old age. So that can be, the stereotype of like grumpiness or isolation, or not wanting to go out and not wanting to meet new people. So there's the self-embodying, but then there's also that social rejection from communities. And then the last path was more of a age-based discriminatory practices on a more societal level. And they did also find that, so it's creating strong senses of community, participating in community with stratified age groups does seem to confer some cognitive benefits, and of course reduction in risk of developing depression. Now, an important consideration as clinicians is, how do you make sure that you're screening appropriately and you can actually help individuals identify that they are depressed? And it did seem that older respondents may deny symptoms either from social or cultural norms, but they can also have an overwhelming response to these very long questionnaires. So the recommendation from this 2010 study was actually keep many of the screening instruments as the 10-item Kessler psychological distress scale. So like 7 to 10 questions, which are shorter and I guess more appropriately designed for this population, for those older respondents, seem to confer a benefit there in terms of diagnosis earlier. Another one that always seems to get under assessed is libido and sexual health in terms of intimacy and that connection piece, for particularly for loneliness. In 2009, this study of 57 to 85-year-olds reported that there was at least one bothersome sexual concern. So certainly addressing that, if there is a relationship between drug and supplement prescriptions that can be impacting elderly adults, that will worsen any sexual or cause any sexual dysfunction, needs to be addressed. So certainly treat those comorbidities, but then also treat the psychological aspect of having perhaps some diminished libido or sexual dysfunction. So consider the polypharmacy, consider that there is a lack of screening, and do engage in that discussion in a healthy, safe way for those patients. Whew, so I went through a lot there. So to sum some of that up from a metabolic perspective, really focusing on improving the cellular health so that there isn't accelerated cellular aging that is going to complicate and feed into development or progression of chronic disease, reducing toxic burden by decreasing exposure and increasing clearance through supporting the liver metabolism and renal clearance. Cardiovascular and respiratory, of course, engaging in regular cardiovascular exercise, improving your nitric oxide production, having a very flavonoid-rich diet, such as Mediterranean diet. Digestion, again, promote that optimal nutrient absorption by eliminating any foods or exposures that are increasing your inflammation in the gut, heal the gut, and reestablish a healthy microbiome through foods and or supplements. Provide the proper doses and formats of any nutrients if you're trying to supplement and replete anything. From a cognitive perspective, increasing that BDNF, protecting brain function with regular exercise, the healthy fats, and from a structural perspective, sufficient protein to reduce that sarcopenia, weight-bearing exercise for bone health, and sufficient bone mineral consumption, reducing joint inflammation, and mitigate the accelerated extrinsic skin aging with that topical protection. Okay, so those are the, this population needs, they have very specific needs. How do we actually now marry that concept with making sure that your clinical practice is supportive and a safe, accessible space? And that can be the actual physical space and the accessibility of that space, but then also the policies and training and standards. These are the things that inform someone's concept and their experience of it, and can actually highlight some of those, again, those biases. So again, that insidious form of ageism is the one that is very implicit, that we don't even notice happening, and this happens from a lack of awareness. So increasing your sensitivity and anti-bias training for your staff, having stratified staff which have different age ranges, different intersections of ethnicity, race, education level, and within that space, so that you have that increased interaction. Recognize if your policies and procedures do have any ableistic undertones or are preventing someone from seeking that care or may deter someone from seeking your care. Audit your language, particularly in terms of anti-aging rhetoric. So it's the very concept of anti-aging. And then there was something called the communication enhancement model, which was developed in 1995 and was really trying to address the need for accommodation without patronization. So without that elder speak, but still being cognizant of those communication delays and declines that may happen with some of those other comorbidities. So increasing accessibility can be done quite reasonably and quickly. Those can be upgrades to reducing physical barriers for transport between your offices, increased space and access points. Those are, again, governed a lot by the regulatory bodies for proper wheelchair accessible bathrooms and things. But other things you can do is adjustable visual and auditory options and higher contrast, larger font, having auditory sets, having translator and translation technology available, or considering bringing those in. And then again, ultimately, recognition of the bias can help mitigate and reduce any underlying biases that may be arising. There's lots of references because there's been a lot of studies on this, and it is an important time to take stock of how we treat our aging population, how we treat every part of our population to create this kind of harmonious space while still providing and understanding future risks and future care and highlighting that importance. So I thank you all for your time. I motored through that, but I would love to hear if there are any questions that I can address, any discussion points that anyone would like to chat about.
Yes, thank you. I turned on my camera for a second. I'm going to apologize if it's a little loud in the background, but let me know if you can hear me okay. Yep. Dr. Nibber, perfect. So we did have a couple questions come through. Some great feedback, great presentation, lots to cover. I know you did cover a lot, so thank you for that great presentation. So the first question that came through, and I believe you answered it, so there's a second part to it, but I'm going to repeat the first one just for kind of the follow-up. Do you treat a biphasic pattern or accept it as is?
Accept as is, and the reason being is I think there is a sufficient evidence to say that there are multiple phases throughout our lives where we will need or not need more sleep, but unless it is either accelerated and happening earlier than we would anticipate, so like happening in our 50s, and it's very disruptive to an individual's life, then certainly maybe considering that. But there does come a point where it's like, well, it's fine. You have a biphasic pattern. That's fine. Because with a change in circadian rhythm, we know that that has downstream effects to also changing our neurohormone and endocrine system and those signaling patterns. And over-treating can then also cause, this other cascade of effects that we don't necessarily know is very well characterized. So, yeah.
And kind of part two, or to follow on to that, how do you like to support multi-phase deep sleep?
So, yeah, sleep and insomnia is always a very individual dependent. So I'll always do an audit and assessment of sleep hygiene practices and the specific triggers that are waking individuals up. We do also know that there are some polypharmacy considerations and perhaps some drug interactions or supplement interactions that actually, if they're just taking them at the wrong time, may change their sleep pattern. So that is an important assessment to do. And then the actual management of those, of ensuring that the sleep phase is not dysregulated and that an individual is getting a proper deep sleep phase, a number of deep sleep phases, sometimes ends up just being a need for a sleep study. So ensuring that they get, if it's super disruptive, just doing a sleep study with them, and actually seeing when they're getting into their phase 3 and when they're coming out of it. And then the management can either be bright light therapy with or without melatonin, and just, again, a lot of it can end up being light entrainment therapies. Some can be sleep hygiene, and then some can be actual metabolic support. So particularly if they're just waking up in the middle of the night, looking at blood sugar dysregulation, if that hypoglycemia is kicking them out of that sleep cycle, then certainly addressing that first. I addressed a lot of things in that answer, but I guess the workup is going to be the most important in understanding what is causing that multi-phase sleep cycle. I'm assuming if that's in like an older adult that is mono or biphasic.
No, that's great. A couple questions came through too on, I guess, maybe your recommendations. So the first one are, do you have specifics on mushroom extracts beside lion's mane? Do you have any others you like?
You know, I think like specifically for increasing BDNF, I'm guessing that they're talking about. The lion's mane seems to have the strongest research with BDNF. It's like when we always talk about doctrine of signatures, which I think is so poetic, but it even looks like kind of that dendritic shape, and it seems to be related to increased BDNF production. Now, I would anticipate and imagine, and this is again still a hypothesis, that a lot of the mushroom extracts have those, because mycelia have these extensive networks, almost like these neural networks, that there is some sort of like enhanced communication pathway, and so there may actually be a benefits for improving BDNF with many other species. I don't know if I'm the expert in and would be able to speak to that, but mushrooms are awesome and they're very cool, and I want to learn everything about them. So I don't know, maybe I'll check back in a few months because yeah, there's just always new information.
Yeah, I was going to say they're trending too. I think there's a lot of documentaries and fun kind of new ways to look at them. So I think mushrooms are definitely trending.
Yeah, they're gonna save us all.
Yeah. I'm probably gonna pronounce this wrong, but there's a question that came through that they'd like your thoughts or your understanding on strontium citrate. Some say it helps build bone density, others say it could cause bone issues. What are your thoughts?
Yeah, I have heard this also, that there's a concern. So with strontium or any mineral supplementation, we are looking at two things. One is, what is it bound to? And that will change its absorption pathway. Strontium citrate, as we know, has kind of that medium to moderate, it's well absorbed, but it's not like it's using those citrates transporters. So with strontium citrate, the necessity is going to be based off of the overall mineral intake. So what else is being absorbed and when? We generally tend to supplement strontium on its own, separated from, we don't want that competitive inhibition with other minerals such as calcium. So it becomes a little bit difficult. I mean, certainly there's a lot of research that is looking at just strontium on its own and potentially providing a benefit. But yeah, there's lots of, it seems like absorptive competition, and that is why we recommend taking it separately. Yeah.
Yeah, no, that's great. I'm conscious of everyone's time too, so I'll do a couple more, but I know there's more coming in. So I will say there's more questions, webinars at fullscript.com, and we can try to maybe connect with Dr. Nibber afterwards and answer some, or hopefully we'll have you on again. But the next one that came through are, again, your kind of opinion. What are your favorite supplements for senile dementia?
Ooh. Okay, so there's a difficulty in terms of the senility. The traditional pharmacotherapies often are these anticholinergics, and that can confer some potential risk in terms of interactions. But again, things like the COPA, things like some of these mushroom extracts. There's some interesting research on homotaurine in terms of reducing the rate of hippocampal atrophy in a very specific Alzheimer's population. So again, a lot of it is very preliminary research, but what's interesting is that's also reflective of the fact that even in the pharmacotherapies is somewhat limited for management of senility. So it sometimes is about mitigating the side effects of the anticholinergic. Sometimes it's just about reducing or preventing additional atrophy, and then also ensuring that they're getting sufficient fats, and that there is a nutrient, like sufficient nutrients, and that absorptive capacity isn't exacerbating or expediting a cognitive decline because they're actually just nutrient depleted. But yeah, it becomes quite tricky. I think that is certainly something to keep looking into, and probably something we'll learn more about. When I do my mushroom research, I'm going to look into that, because now I'm just interested, and now I want to.
Yeah, that's great. So there's a couple more coming through, and it's a lot of thank yous. There is kind of one more I'll probably end off with, and it's kind of like, again, basic kind of question for you. At what age would you start supplementing for cellular health?
Okay, that's a great question. I like that. So supplementing specifically for cellular health is, I think it's more about increasing those natural factors. I know I did mention, things like the oxaloacetate or NAD, NR, nicotinic ribonuclease, NR. I don't know why this is escaping me, but there are a lot of these supplements that like support that aging process. So those are for individuals, I think, that have chronic conditions that make them somewhat metabolically inflexible. So I would say, conditions like thyroid dysfunction or PCOS, or have just come off of a very singular metabolic diet. So let's say they were just on keto and they never did any carb cycling, to help with that metabolic flexibility, then perhaps supporting those mitochondrial pathways is helpful. But ultimately, I think the goal is always to just get that from our lifestyle. So really doing those alternating HIIT exercises, switching up our macro intake so that we're not singularly dependent on one type of macronutrient, and then again, all those lifestyle factors like sleeping well and reducing stress. You know, those things that are so easy to say, but
so easy.
harder to do.
Well,
yeah.
oh, sorry, I did not mean to cut you off there.
No, I was just trying to think of, like, I guess light entrainment would also be a good one. But yeah, it seems like that's a non-answer, but it just seems like, yeah, we only really want to supplement when you could start very early. I guess we don't have enough human clinical evidence to say that, because remember, longevity studies, most of them are in animal models. And if you're going to do a longevity study on yourself, start taking it at when you're pretty young and see what happens. But yeah, there's a huge lack of longevity clinical data. Good quality.
Well, that was great. I know we could probably talk all afternoon. This is a very engaging topic, and I thank you for bearing with potentially some noises in the background. And thank you so much, Dr. Nibber, for being here with us today. Those who are still attending or who registered will get access to this recording after the webinar. You'll get an email. You can also follow up at webinars@fullscript.com if you have any more questions. Upcoming webinars are on fullscript.com/webinars, and we hope to have Dr. Nibber back with us again to maybe continue this conversation with AOR or any other topics in the future. So we hope to see you again.
Thank you. I'm going to work on this mushroom presentation.
Yes, we love it, I'm sure. So thank you all for attending, and keep an eye on your inbox, and we hope you have a great rest of the day.
Thanks, everyone. Bye.
Bye.